Good morning. We're almost there. Chetan, thanks for joining. I already see you. And I also see that Chris Osborne is already on, so we have both authors here. It's early in the year, so I heard that some people are still on vacation, and so it's maybe not as busy today as usual. I feel a little bit sorry for these two fantastic papers. But we will have an interesting discussion anyways, and this is being recorded, and I know for a fact that a lot of these are viewed then, especially in Asia or Australasia, and so it's good that this is going out there. So we'll give it another minute or so to let others join in, and I see that number is coming in now. And we'll start with you, Chetan. Is that okay?
Yeah, that's fine with me.
Hi, Chris. So you know the format of the CMR Journal Club is pretty informal. So you just use screen sharing to walk through the PDF and to highlight on the most important things, not so much on the technical detail, and within 10, 12, 13 minutes, and then we'll discuss that. And the papers, for those who want to go into more detail, can be downloaded and then scrutinized there. And yeah, so as I said, we'll wait just a little bit. Although usually we start pretty much on time, but I know some people are just getting in there, and so we'll give it a few more minutes. I hope everybody came good into a new year, which hopefully comes with more peace, less pandemic, and more normalcy. Let's hope for that. I'm back in Montreal. I'm back from Europe, where I spent a few weeks with family, and the year starts off with less stress than usual. So I think that's a good sign. Okay, so welcome everybody to today's CMR Journal Club, the first of 2023. And this time we have two really outstanding papers, both on cardiomyopathies, both of course using cardiovascular MR, and both published in top journals, and both with very important data. And we'll jump right into the first one, which will be presented by Chetan and Shenoy. You can already, if you want, start sharing your screen. So thanks for coming. The paper has been published in JAMA Cardiology, and it's called Cardiovascular MR Imaging Phenotypes and Long-Term Outcomes in Patients with Suspected Cardiac Sarcoidosis. And sarcoidosis is one of the diseases that come with relatively in this case, not necessarily always specific, but sometimes typical tissue characteristics. CMR is, of course, the tool of choice to understand and also diagnose the disease. So, Chetan, take it from here, and thank you already for coming.
Sure. Thanks very much for the invitation to talk about our paper, Matthias. So before I go through the paper, I want to give a little bit of background. And the background is more to explain why we did this paper and how we got here. And I will say that even though the title and everything says and suggests that this is a prognostic paper, in a way, it's almost equally a diagnostic paper, if not more. And I'll explain what I mean by that. So as a background, so I'm a CMR and also a clinical cardiologist. And like many of the people in the audience, I have been sort of frustrated with how we diagnose cardiac sarcoidosis. And I think we all agree that we call or we think about cardiac sarcoidosis when we don't have an obvious explanation for what we are seeing. So it's often a default diagnosis. And the general perception is that cardiac sarcoidosis can present with any LGE pattern or even without LGE, or LGE that can mimic an MI. And so it's often called the great masquerader. If you see papers and on tweets, people often call that the great masquerader. So a few years ago, we became interested to try and understand if this is true and whether there is any particular phenotype or LGE pattern for cardiac sarcoidosis, or perhaps there isn't anything. And the main paper that led to this belief that cardiac sarcoidosis can present like anything came from a 2009 paper published by the Duke Group, where they showed examples of patients with isolated subendocardial LGE, which looked very much like an MI, but the patients did not have any coronary artery disease, and it was attributed to cardiac sarcoidosis. So this is a Patel et al. Paper from Circulation, which is highly cited. And this became the main basis for our belief that cardiac sarcoidosis can appear like anything and everything. And so a few years ago, we decided to look into this. And here's the problem. With cardiac sarcoidosis, we almost never get a definitive diagnosis, because a definitive diagnosis can only be made with cardiac histology. And we very infrequently or very rarely do a cardiac biopsy for many reasons. One, we believe it is low yield, and second, it's not very safe. And so we don't really have a ton of data on patients with definite or cardiac histology proven cardiac sarcoidosis. And so we decided to look at the pathology literature. And so this is what we started out a few years ago. And I'll share my screen. And this is not the paper that we are discussing, but this is actually the background that led to the JAMA Cardiology paper. And so in this paper, we looked at pathology data. So we looked at case reports and case series of cardiac sarcoidosis, which was histologically proven. And we looked at the patterns. So we looked at patterns of cardiac damage. So in a way, this is human learning. So this is not machine learning, but we actually looked at the images and we said, how do the patterns of cardiac damage look like? And so we analyzed it. So in a way, this is not data that is in the papers, but we looked at this and we looked at how the damage looks like. And this is exactly what we would see on CMR as LGE. And so in this PDF, we included every single image. So you can look at this and learn for yourself. And so we systematically interpreted these images, and we found out that there are indeed patterns, some patterns which are frequent and some patterns which are not frequent or rare. And so these are the two tables. And so these are the patterns that are very frequent, seen in 90 or 70% of patients: subepicardial, subendocardial, transmural, multifocal. And then some features are rare or never seen. And so this is what is, I think, the most important message here, that we never see isolated subendocardial involvement or isolated mid-myocardial involvement, or we don't see cardiac sarcoidosis without any obvious cardiac damage. So this was the background for the paper. And the main criticism, and this is very valid, is that these are patients who are end-stage cardiac sarcoidosis, because by design, these were people who had either died and had an autopsy, or they had a heart transplant. And so is this true in patients who are not end-stage cardiac sarcoidosis? And so for that, we needed to look at people who are living and people who had a cardiac MRI. And so that's how we started, and we ended up with this JAMA Cardiology paper. And so here, again, we are left with the same dilemma. We don't really have very many cases with cardiac histology proven cardiac sarcoidosis. So we decided to look at outcomes. So there is no way to prove who or which of these patients definitely has cardiac sarcoidosis, but we can use outcomes as a guide. And we know that cardiac sarcoidosis is very arrhythmogenic and very bad. And so if we find a particular group of patients who don't have any arrhythmias, then it is very helpful to know that we don't need to think about an ICD. We don't need to worry about treating them with immunosuppression. And indirectly, we believe that we can say that those people probably don't have cardiac sarcoidosis. So essentially, we took the same patterns from the JAHA paper, and we looked at our database. And this is a database of patients who were scanned over 16 years. And so we had 504 patients, and these were all biopsy proven outside the heart. So these are all sarcoidosis, which is biopsy proven, and only about 20 of them had tissue diagnosis in the heart, but everyone had a diagnosis of sarcoidosis. And I will jump straight to the figure. And so what we saw is among these 504 patients, these were all people with suspected cardiac sarcoidosis based on clinical suspicion. So these are not screening. This is people where they had either an echo abnormality, EKG abnormality, or symptoms that were suggestive of cardiac sarcoidosis and were referred to us for a cardiac MRI. And we found that about 58% of them were entirely normal, which meant that they had normal EF and no LGE. And of those who were abnormal, interestingly, we found 10% with abnormal EF but no LGE. And then in the LGE, 2/3 of them fit into those frequent patterns we saw in the JAHA paper, and 1/3 of them, of all people with LGE, fit into these pathology rare. So who's the pathology rare? So this is essentially isolated mid-wall, isolated subendocardial LGE. And so then we looked at their outcomes. And so this is the outcome Kaplan-Meier curve here. And you can see for arrhythmic endpoint, the group with the pathology frequent LGE had significant arrhythmias, whereas all the other groups had excellent outcomes with hardly any arrhythmias. So you can see there are 3 lines overlapping here, which is close to 0. So there were hardly 1 or 2 events in these groups. And this includes the group with what we call pathology rare LGE, so 1/3 of patients with LGE. This also includes the group who had abnormal EF but no LGE, so they had no arrhythmias. And when we looked at the heart failure endpoint, we again saw that the group with pathology frequent LGE had the worst outcome, but the other groups also had some outcomes, which is not entirely surprising because they had low EF and they had some pathology. And so in essence, we believe, and there's no way to prove this, but we believe that this group with the pathology frequent LGE patterns that we found on the pathology actually represents true cardiac sarcoidosis, whereas the other groups do not represent cardiac sarcoidosis, even if they are abnormal. And so what explains these abnormalities? Well, there are many things. One, subendocardial LGE could very well be CAD. And yes, some of them don't have CAD on coronary angiography, but that doesn't mean that they don't have MINOCA. And we have extensive literature in recent years about MINOCA. And similarly, mid-wall LGE could be from pulmonary hypertension or other causes other than cardiac sarcoidosis. And similarly, abnormal EF without LGE, we don't think it represents cardiac sarcoidosis. The reason for the abnormal EF could be many things related to the general sarcoidosis, could be stress cardiomyopathy, it could be non-ischemic cardiomyopathy such as genetic cardiomyopathy, but we don't really think it's cardiac sarcoidosis. And this is important because we don't think these three groups need to be treated with immunosuppression, and we don't think these groups really need an ICD. So it is this particular group that needs an ICD, which is a subset of patients who are abnormal. And these are examples of the four categories. So normal did fine, abnormal EF, no LGE. They have heart failure events, but no arrhythmic events. This is the pathology frequent, which we believe to be true cardiac sarcoidosis. They have arrhythmic events and also a higher risk, a relatively higher risk of heart failure events. And then pathology rare. And so this is a case of isolated subendocardial LGE, where the patients did not really have any arrhythmic or heart failure events in this subgroup. And so I think I will stop there and I will take questions. So we did not really look at T2 in this. So this is a group from 2004 to 2020, so 17 years cohort. So we did not really have a lot of useful T2 imaging. We have been doing T2 mapping in recent years, in the recent 5 years or so, but not enough for us to look at outcomes. So hopefully in a few years, we'll have data on the use of T2 and T2 mapping in this group. And one of the limitations of T2 here is that we are scanning more and more people with devices. So they had devices for AV block with pacemakers, who then they suspect whether they have cardiac sarcoidosis or not. And so far, we don't have a mapping sequence that is compatible with the people who have devices. So the sequence we use has a SSFP readout, and the quantitation is not quite reliable. I know Siemens is working on a GRE readout sequence, and hopefully in the next near future, we'll have reliable T2 mapping and T2 imaging in patients with devices. So essentially, we are left with CINEs and CMRs. And then if we are suspecting that these patients have cardiac sarcoidosis, then they undergo FDG PET, which is what we use to look for active inflammation in these patients, which I believe is the practice in most centers in this world.
Thank you very much. That's very interesting and intriguing. So someone has a question, you can just post it or unmute and then speak up. My main question is, and I absolutely agree with what you said, it's just that can we be, or do you feel comfortable enough to say, okay, just because the outcome is so different, one is sarcoid and the other one is not? How can you exclude that you catch these patients at an early stage where the outcome that for those years that you have assessed did not necessarily show that yet, but down the road it will be? So isn't there a risk that you basically give a green flag in this patient and then they will forever go on and say, no, an MR has excluded sarcoid, but then years later there's an event?
Yes, absolutely. And sarcoidosis is not a one-time thing. It's a chronic disease process. And so a patient can develop cardiac sarcoidosis at any point. But what we know based on this paper and other paper is that we don't see frequent development of cardiac sarcoidosis. And in this group, the median follow-up was 4.3 years. So we have data at least to 3 to 4 years. And there are other papers also showing an excellent negative predictive value for LGE. So if you don't have LGE, then you will do fine, at least for 3 to 4 years in this subgroup.
Yeah.
But beyond that, yes, obviously, and we need more data on how often to scan these people. And we are looking, so we are working on on a paper to look at the subgroup who had longitudinal imaging, so more than one scan. We have about 160 patients. So we are going to see, is there such a thing as a warranty period, or, what's the frequency where someone is deemed to be low risk or, not having cardiac sarcoidosis, but subsequently develops high risk or cardiac sarcoidosis. So we hope to publish that. It will be a subgroup of this patients, but we anecdotally, we don't really see a lot of this. And essentially, I think the simple explanation is that true cardiac sarcoidosis is actually rare. We think that we are missing this a lot, and we hear about it a lot, and we call a number of things as possible cardiac sarcoidosis, but we are finding that a lot of these cases actually don't have true cardiac sarcoidosis. We are seeing increasing number of patients with genetic cardiomyopathy who are referred to us as cardiac sarcoidosis, various forms, desmoplakin, laminopathy, and other things. And so, yes, you're right, there is no guarantee for life, but at least for the short term, I think there's enough data to say they don't need a ICD for the immediate future.
Yeah, I think it's still relevant because we know that if people have sarcoid, what threatens their life most is the cardiac involvement. So I agree, it's not that often, but if you can diagnose cardiac sarcoidosis, that means a lot for that patient. Okay, there's one question. We already are running a little bit over time. I'm sorry, one quick answer if possible. Did you study RV ejection fraction and RV late GAD prognosis?
Yes. So we did look at RV LGE, and so RV LGE would be RV free wall LGE, and we do believe that it is one of the pathology frequent patterns or patterns that we see with cardiac sarcoidosis. Because MRI is not great at identifying RV free wall LGE because RV free wall is thin. And I'll refer you to Matthias' editorial, which he published recently, which was very interesting, discussing the limitations of CMR for imaging the RV free wall. So we don't see the same frequency as we saw on pathology. In other words, in the pathology literature, nearly 90% of patients have RV free wall involvement, whereas on CMR, it's much less frequent simply because we don't see it. But we did see it, and it is included in this. And we have a separate paper in JACC imaging where we focus solely on the RV, and we talked about RV-EF versus RV-LGE. So you can read that paper.
Okay, thank you very much, Chetan. Fantastic. So if you unshare your screen, then I would ask Chris Orsborne to share his. Chris is coming from Manchester and will present the paper. He's the first author published in JACC. And it's also about a cardiomyopathy that isn't deemed not very frequent, but where cardiac MR, especially with T1 mapping, plays a significantly more and more important role. And some people say that Fabry is the only disease where T1 mapping really always helps. So I'm looking forward to your paper, which is entitled Validated Model for Prediction of Adverse Cardiac Outcome in Patients with Fabry Disease. Chris.
Thank you very much, and hello everyone. Thank you for a very interesting session thus far. My name's Chris. I'm a PhD student based in Manchester in the north of England. I'll talk you through our recent paper. Just to give a little bit of background initially, as we've said, Fabry disease is a very rare inherited lysosomal storage disorder. It's an X-linked disorder where patients develop a deficiency in an enzyme called alpha-galactosidase and the accumulation of its substrate, which is called globotriacylceramide or GB3. And GB3 accumulation affects lots of organs, but it's the cardiovascular manifestations that are the leading cause of death. And although it's X-linked, the cardiovascular manifestations affect greater than 50% of men and women. Despite this, identifying which Fabry patients are going to go on to develop adverse cardiac outcomes is severely limited, and it's limited by a paucity of prognostic data, and in particular a paucity of robust prognostic models and risk estimators, such as those that exist in other cardiomyopathies characterized by similar findings in LVH, such as the ESC risk estimator, which we use almost daily in the UK to guide clinical practice. So consequently, or as a result, the management of cardiovascular Fabry disease can be rather variable. It can also be rather impersonal or not personalized, and its cost effectiveness is unclear. And as a result, it's rather difficult to know which patients to treat. And that's important because treatments are available for Fabry disease. Of course, we have intravenous enzyme therapy and we have oral chaperone therapy. Both are very expensive. They cost over £100,000 per year. And currently, the way in which we identify patients that are at risk and treat them is based on clinical experience, often by individual clinicians in individual centres, or by individual parameters such as left ventricular wall thickness that we know from our experience from other conditions are unlikely to give a full, fruitful estimation of patients' risk. Therefore, in light of that problem, we set out using a large cohort of Fabry patients undergoing clinical CMR to identify prognostic factors that predicted adverse cardiac outcome, and also to build a prognostic model in these patients. We chose to incorporate CMR because obviously CMR imaging biomarkers have become embedded into clinical practice of Fabry disease, as we said, in particular T1 and also T2 mapping, but particularly T1 mapping. And although they are embedded in clinical practice, the prognostic significance of those biomarkers has not always been completely clear. We also, as part of our study, developed our own sort of in-house imaging biomarker called T1 dispersion, which I'm just going to flick to figure 1 now and show you. So part of the problem with T1 mapping in Fabry disease is that it goes down as you get GB3 accumulation. GB3 is a lipid, so it's a potent shortener of T1 time. And then as you go into the more advanced phases of Fabry disease, you get fibrosis, and then T1 starts to go up. So there's this period in the middle where it pseudo-normalizes, and that makes it quite a problematic biomarker for prognostic modeling. It makes it very difficult to model. We hypothesized that perhaps the spread of T1 values might better reflect prognosis. So essentially, we designed a script which extracts every voxel or pixel value in a T1 map in the middle third of the myocardium, as demonstrated here, and then essentially plots it on a histogram and works out the dispersion of the data. And what we hypothesized was that the greater spread of T1 values would equate to poorer prognosis. And I'm just going to demonstrate this here. Hopefully you can see my pointer. We've got 3 patients with Fabry disease. The patient on the farthest left is completely unaffected. They have a GLA mutation, but they don't have any manifestations. And you can see that their T1 values are quite tightly packed around the mean, and the mean is the dotted line here. Your middle patient has got left ventricular hypertrophy, but doesn't have any LGE yet. And you can see that the distribution of the T1 values are rather wider in this patient. And the patient on the right has LVH, but he also has basal infralateral fibrosis. You can see there's some higher T1 times just down here, which are LGE when we give GAD. And you can see in this patient that there's quite a big spread of T1 values, and you also get this tail of high T1 values, which we see in patients when they have LGE, when they have fibrosis. And these are all pre-contrast T1 maps. So, and that's quite important because a lot of these patients have renal disease and we can't always give them GAD. So this is quite a good measure. So the patient on the left had a low T1 dispersion, a low spread, patient in the middle higher, and the patient on the right really quite high T1 dispersion. The thing I draw your attention to is that the dotted line for patient 1 and patient 2, the T1 values are just over 900. So it just demonstrates that there can be a significantly different distribution of T1, but actually the overall T1 value can be very similar. So we incorporated this into our models. So we prospectively and consecutively recruited 200 patients with genetically confirmed Fabry disease attending our centre for routine clinical CMR. And we analysed all of the scans in CVI-42 as per societal guidelines and measured T1 dispersion as I've described. All of the patients are followed up at a single centre, so we were able to develop quite a broad composite endpoint for these rare patients, incorporating all of the relevant things that happen, including arrhythmia, admission for heart failure and cardiovascular death, and via an exhaustive notes review and reviewing annual device checks and annual 24-hour cardiac monitors, we were able to identify patients that had and had not had outcomes. We used quite a complex statistical workflow that I'll overview. We used Cox regression modeling. The time to composite endpoint was defined as the time to the first event or sensitive the date follow-up if no event occurred. We used multiple imputation and bootstrapping in order to account for missing data. And we specified the model as detailed here, which is a derivative of the Cox equation, exactly the same method that was used for the ESC risk estimator. The results were from our 200 patients. We had an annualized event rate of 4.8%, which was relatively high for this group of patients. Strikingly, there wasn't a huge difference between men and women. We often think of, in an excellent condition, that the males are going to be the ones that are badly affected and the females aren't. That wasn't necessarily the case here. And then we went on to build our models. And we did that first by doing univariable analysis for each of the relevant baseline clinical factors. We saw which of those were the most predictive. And then based on the existing one variable per 10 events method, we selected the 5 most predictive variables to input into our prognostic modeling development procedure. Now, 2 of those top 5 were maximal wall thickness and left ventricular mass index, both of which were highly correlated, as you would expect. It isn't good practice to put highly correlated things into prognostic models together, so we chose to develop 2 models, one consisting of age, QRS duration, maximal wall thickness, global longitudinal strain, T1 dispersion, and the other exactly the same, but instead of maximal wall thickness, we incorporated left ventricular mass index instead. So I'll show you how model 1 turned out. So this is model 1. So this is the model that included maximal wall thickness. The 3 variables that were selected following the competitive modeling development procedure was age, T1 dispersion, and global longitudinal strain. This is the top graph here. It separated the patients really well into low, medium, and high risk groups. However, the model was poorly calibrated. So these are calibration plots, and what they assess is how well balanced the model is over the full spectrum of risk. It's no good having a prognostic model that really effectively classifies low risk patients as low risk if the high risk patients are all being misclassified. So what should happen with this graph is all of these lines should lie along the black line, which is the reference line. Unfortunately, model A significantly underestimates risk in high-risk patients. So underestimating risk in high-risk patients isn't good. It means that we could miss a patient and not give them an intervention that they require. However, model B, which selected age, T1 dispersion, and left ventricular mass index, separated the patients out equally as well, but was really excellently calibrated. So this model splits the patients up into groups very effectively, but it also does so effectively over the full spectrum of risk. So it doesn't matter if you're a low risk patient or a high risk patient or anywhere in between, it performs really rather well. So just to summarize, what we've done is we've taken an area in which prognostication is rather challenging, and consequently patients are not necessarily always getting sort of effective, cost-effective, high-performance care. And what we've tried to do is develop a robust prognostic model and risk estimator such that these patients can be more accurately described and understood in terms of what their behaviour is likely to be. We hope that a tool like this would supplement decision-making for patients in future, provided that it can be externally validated in another large cohort, which is part of ongoing work, and may lead to either intensification of treatment in some patients, but also potentially the de-intensification of treatment in other patients, such that they can be managed effectively and appropriately. I'm more than happy to answer any questions as they come.
Yeah, thank you very much. Very well presented and really very interesting data. Do you, you already answered one of my questions is, what about the validation now in an independent cohort? So that's good to know, or that you mentioned that this is ongoing. This is great, but let's say this can be confirmed. What could be a practical tool or approach of clinicians now then to apply that? So do you need a special software for that, or is there a website where you can jump in and type in data and then get a result, or what would be the next step in the knowledge translation?
I think the next step would hopefully be, once we're externally validated, we would recalibrate all of the coefficients in the model, and then a website, an online resource would be the best way of doing this, in a similar way that the ESC risk calculator is. And I would hope that when we're sending patients for CMR, certainly at our centre and others, that these variables can be kind of picked out in the report, and then for Fabry patients. And then what we can do is incorporate that in clinic into a risk estimator, and then have an inclusive conversation with the patients about their risk and what that means to them, and how we could potentially modify the risk. And I think the kind of pipe dream with this is to be able to say to patients, and there would be a lot more work involved, but be able to say, this is your risk now, and this is what we think your risk might be if we were to commence you on some therapy, and this is what we would recommend, but we're happy to have a conversation with you about it. I think that would be the great way forward.
Okay. We are already going a bit over time, but still there. Of course, you also ask yourself that typically in risk stratification, what is a little bit overlooked is that the pretest probability plays a huge role, and that we probably should more look for pre and post test probability than just for risk alone. And the other aspect is that risk at a certain time point may be less, and this is a discussion that's currently ongoing in the lipid research. The earlier we can detect a lower risk, the more the overall benefit would be in correctly diagnosing. So wonder what your thoughts are there. And then my last question would be T1 dispersion. Is there a problem with scanner variability, scanner associated variability, or can we rely on, let's say, the applicability of this important component of the risk stratification tool here among different vendors and techniques?
So we are doing some more work on T1 dispersion across multiple scanners and sensors. So we should have that answer hopefully relatively soon, because it's not looking at raw values. It's kind of a second order effect. It's naturally more robust than raw T1 values, which is very good. We're not sure whether at 1.5 all these patients are scanned on the same scanner at 1.5T. It may be that at 3T you get slightly different values, and it may be that we can adjust, we can introduce an adjustment for that. We'll wait and see on that. In terms of risk stratifications on this patient, I think particularly in Fabry we have quite a long way to go. I think every patient with Fabry should have a CMR at some point in their care, ideally when they're referred, just so we can get a baseline. And that isn't a commonly held view across the world, however. A lot of people do rely on echo and ECG. So I think that I take your point. The earlier we do this, and the earlier we risk stratify, the greater the cumulative effect. And we know that Fabry is a very slowly progressive condition, and the treatments don't reverse anything. They're there to stabilize as further changes. But I think that applying this kind of deep phenotyping early using CMR is the right thing to do. And I think we'll learn a lot from doing that as we go.
Yeah, I totally agree. So then last, before we adjourn, from Mohamed, a similar question on how to tell true T1 dispersion from suboptimal T1 map motion correction or artifacts caused by arrhythmia. What are your thoughts on that?
Fabry patients are really challenging patients to scan often. Because they do have a lot of ventricular ectopics and other arrhythmia, which makes it difficult. As I say, in our study, if there was any doubt over the quality of any of the data, then in a research study, we obviously couldn't include it, and we imputed it in order to account for missing data, which is very robust. that is one of the limitations of the work, in that you are relying on decent images. What we have found is we have used some automated analysis for our wall thickness and left ventricular mass measurements. We've actually reanalyzed the model. This hopefully will come out at some point, and it performs similarly robustly. And the next step will be to see if the automated analysis for T1 and T1 dispersion does the same thing. Now, it will be interesting to see whether actually automated T1 analysis might actually help us in terms of a reproducibility of measurements and help us with that. Yeah.
I was very pleased to see that you included papillary muscles and trabecles in your mass. As you may know, I'm one of the proponents of doing so, using an anatomically correct method, partly also because hypertrophy happens often there first. So do you also agree that in Fabry it's the same thing, that the hypertrophy often kind of is more prevalent or more prominent in this part of the myocardium, which would be in a kind of a simplified contouring method would be overlooked?
Yeah, I think it's very important in Fabry to include papillary muscle mass in your calculations. Just anecdotally, some of these patients have absolutely massive papillary muscles, and it seems crazy not to include it. Yeah. The other thing that we do see is in Fabry is papillary muscle fibrosis, and it can be quite extensive as well. So there's definitely a disease process going on there, and I think it's very important to include it.
Okay, thank you so much, everybody. Fantastic journal club today. I will, against my usual, I will tweet a post CMR journal club and point to the recording. Really enjoyed both papers. Fantastic presentation, important results. So yes, there are patterns in suspected sarcoidosis that mean a lot, and the chameleon that we think of cardiac sarcoidosis may not be as complicated to understand in terms of its clinical relevance. So that was very good. And then that a risk stratification tool using MR data and other data may be a better approach to diagnosing diseases or cardiomyopathies than just relying on a certain imaging related marker. So good learnings here. All the best also for the year. For the next journal club, which will be shortly after the SCMR, we will select papers shortly before. So I do not announce them right now, but I'm looking forward to seeing you then on February 1st, shortly after the SCMR. And I hope to see many of you. Just if you see me, come by and let's have a chat, and wish you all the best for today and for the year as well. And thanks again, Chetan and Chris, for the presentations.
Thank you.
Thank you.
All the best.